My name is Dr. Gary Greenswag, and I'm here with Dr. Ankita Sagar. We're here to host Grand Rounds this morning. We have three great speakers that we're going to hear about in just a minute, and John Kanishi is here as well. I want to say that this particular Grand Rounds is the beginning of a series that has to do with LGBTQ plus care. We have had a clinical advisory group working for almost a year in establishing a kind of curriculum and path for the physician enterprise as it relates to LGBTQ plus care. I also want to mention that next week will be our inaugural kickoff pilot. What else can I say about it? In-person learning session. We have two paths. Path one is really what should every primary care provider know and understand about LGBTQ plus care, and that's what we're going to hear about today. You may recall that maybe 6 weeks ago we had a PrEP and PEP lecture by our friends from Southern California. It was very informative. It's online, and it really helps people get their arms around PrEP and PEP. So there's that, and then next week, so we have this two paths, and this what everyone should know path, and then we have a path for advanced learners, people who want to advance, take care of more complex patients. And so for the West, we have put together an all-day seminar, which will be next Friday in Sacramento, for people who want to sort of get that advanced designation, and it will be one of a series of in-person and online tutorials and other types of arrangements to get folks up to speed. So we're very excited about that. And Dr. Sagar has reminded me that this is Women in Medicine Month, and she shouldn't have had to remind me, but she did. I'm glad she did, because otherwise I wouldn't have said anything. So there's that. And then also APP week is coming up September 25th, beginning September 25th, and October primary care week. So lots of up and coming activities. And so I think with that, I'm going to introduce our two speakers and one panelist. And I want to remind you that if you have questions, you can either put them in the Q&A or in the chat box, and we'll answer them during our panel. And I know John put a note in the chat as well. So let's start with our two speakers. First, Dr. Mark Goodwin, Goodman, a professor of family and community medicine at the Creighton Creighton University School of Medicine. After receiving his medical degree at the University of Nebraska and family medicine residency at Rush University in Chicago, Dr. Goodman worked in refugee camps in Sudan and Kenya for 2 years and has just celebrated his 30th year of teaching at Creighton. Dr. Goodman's area of interest are patient advocacy, problem solving, LGBTQ care, and HIV care. And joining us, and I want to just say that Dr. Goodman roped Dr. Green into this, so we're very grateful, thank you, is Dr. Michael Green, who graduated from the Offutt Air Force Base Family Medicine Residency Program, and I had to look it up, but Offutt Medical Air Force Base is just outside of Omaha. He served overseas in Afghanistan and Japan, and after serving in the military, he began teaching at Creighton in 2012. He became the medical director of the clinic and then a core faculty member, and has been serving as the program director of the Creighton Family Medicine Residency Program since 2017. His particular areas of interest include LGBTQIA healthcare gaps, as well as healthcare disparities in general. And last but not least, Joshua Lumsden, who is on our physician and APP advisory group for LGBTQ plus care, completed his physician assistant training at the University of Washington in 2016. He is currently president-elect of the Washington Academy of Physician Assistants. He is the chair of the Virginia Mason LGBTQIA plus clinical work group, and his clinical interests include gender-affirming care, sports medicine, mental health, and central sensitization disorders. So with that, I think we'll turn this over, Mark, to you first. Is that right?
Thank you very much, Gary. A strong and amazing hats off, by the way. Brooke, John, Rachel, Dr. Gary, Dr. Sagar, and Joshua. It's an honor to present with you. I'll open by just saying I've enjoyed tremendous support in this work we are doing from both Common Spirit and from Creighton. Creighton is a Jesuit institution, and the Jesuits view care of this community as a justice issue. And we have tremendous support here for this work. And I'm very, very grateful. We're going to say this over and over again throughout the presentation, but, you know, I have found that my essential sort of emotional places work well with LGBTQ care, which are a sense of humor and curiosity and respect. Thank you, Mike.
Yep. So nice to meet everybody out there. Mike Green. I think we can advance to the next slide. I've got the reflection. So kind of as we get started, thinking about the why of why we're doing this. And I was reflecting on our ministry of healing, that's kind of what we do day in and day out as providers, front desk staff, various different aspects of the organization. And I was telling Mark this story that I'll share with you guys. So about a couple of weeks now, I guess it's maybe a couple of 2 months ago or so, I had a young man on my schedule that I'd never met before. And I know he had rescheduled twice to specifically get an appointment with me, and it was a follow-up surgery appointment. But I hadn't seen him before, and he met with me, and the surgery specifically was a hemorrhoidectomy, particularly painful surgery, unfortunately, that sometimes people have to go through. And I was just talking with him and kind of getting to know him. And as he was sharing his story with me, if I could just describe this scene of this young man sitting in front of me, and as he started to talk, he kind of lifted his feet up off the floor, put his knees to his chest, kind of put his arms around his legs, and very much became like in a fetal position. And by the end of talking, he was just sobbing and sobbing. And the story that he was telling me was one of going in for a hemorrhoid surgery, but in the end feeling exceedingly humiliated and ashamed and kind of downbeaten, and wanted to seek further care from me in particular, because he felt like he would not be judged and needed to share this. So what had happened, it was a lot of mistakes by healthcare providers along the way, and many of those could be learned differently through educational processes that we can do and through various different interventions on our part to make people aware of some of the things that we're going to talk about. So that's why we're doing this, is to prevent inadvertent or overt harms like that to our patients. So that's how we're going to start off. Next slide, I think. And we neither of us have any disclosures. Neither Dr. Goodman nor myself have anything. So we're good.
Our two objectives this morning are to sort of identify the historical injuries that have taken place to this group of people, and then to suggest some steps to be taken by providers and the organization in order to promote healing and inclusion. So that's what we're up to this morning.
Next slide.
So this word alphabet, LGBTQIA plus, it keeps growing. And the origin of these words, this is me editorializing a little bit, is an attempt to kind of hide what's going on a little bit, but also to be inclusive. Lesbian, of course, the word comes originally from the Isle of Lesbos, where women loved women. Gay is the jolly, happy, lighthearted behavior that was witnessed among men who have sex with men historically. Bisexual, people who are attracted to both genders. Trans, people whose expressed gender, whose internal sense of self is different from their birth anatomy or birth gender. Sexual orientation can be marked by the word queer, which is a power word, you know, originally a very damaging, difficult, painful word, sort of like faggot. Queer was hurled at people as an injury, as an insult, and this community has taken it back as a power word, as a positive. Intersex, asexual, questioning, all of these things come into play. And so it's the group of people whose sexual orientation or gender identity is a little less orthodox. So that's what this alphabet refers to. We're probably going to shorten this in the course of the talk, by the way, and just say LGBT, but everyone is meant to be included.
Next slide. So, first question for everybody out there. LGBT patients often report which of the following: being denied healthcare, delay in seeking healthcare due to prior negative experiences with providers or staff, or having to teach their providers about their unique and routine healthcare needs, or all of the above. Yep, all of the above. So,
Yeah.
some of the background. Yep.
So I want to editorialize again a little bit and report, in my experience, just about everyone served in this community has some woundedness. There's some trauma, families of origin, church of origin. And so a lot of folks are sort of starting over and reinventing themselves and choosing different families. You know, my community talks about chosen families, our loved ones that might be different from the family we were born in. You know, us primary care folks both wield shame as a weapon and maybe have experienced it ourselves. There's shame around body image and shape, about illnesses such as diabetes or obesity, our choice of sex partner or partners, substance use. And this shame might result in more patient deaths than any other disease in America, because I've been witness to this. I've experienced it. Most of you probably have too, where a provider was giving us a hard time about something. You know, we've had to kind of reinvent ourselves. And I'm a big believer in this notion called a personal mission statement. You know, what's my mission? And my mission is to be an advocate and an idea generator to help people get their goals. And I try really, really hard. I think Mike does too, and perhaps everyone listening in tries really hard not to give people a hard time, not to use shame as a weapon. Next slide.
So just some background information. Throughout human history, same-sex couplings and dissident couplings have existed, sometimes celebrated and sometimes scorned. a little piece of background from me. My bachelor's degree is actually in philosophy. I studied metaphysics, and in doing so, one needs to study lots of ancient Greece. So there's probably one of my favorite dialogues, the Phaedrus, which is Plato's recollection of a Socrates hosted dinner party discussing the nature of love. And it's just apparent throughout that in ancient Greece, the heterosexual and homosexual couplings were quite common. And in fact, one of the arguments that was being discussed at the dinner party was whether it was more profound to love a male or a female. And there were arguments to and fro on both sides. And that was just part of the fabric of society. So at that time, and that's very different than our current North American society fabric. But my point in bringing that up is that it changes over time. Things have not always been this way, and things will not always be this particular way. Humans can choose how we relate to each other differently. So, next slide.
I'm a huge fan of Native American culture. I have the opportunity to pray in a sweat lodge and hang out up at Pine Ridge with friends, learning how to sing in Lakota. And Native American culture often celebrates tribal members who embrace divergent gender roles. In Lakota, the word is called Wankte. And these are men who embrace women's roles in the tribe. Throughout history, there were people born men who chose to be homemakers and to participate in child care and bison robe preparation, who took male lovers. There's also a tradition of women rejecting the female gender norms and becoming warriors and spiritual leaders and medicine women. And again, this is an example of a community of people who took a little different view of all this stuff. Next slide.
So other cultures throughout history may have been much less tolerant than that. Thinking of the Nazis and the pink triangle of the Nazi camps preceding and during World War II. And there are also some various religious teachings that convey censure or disapproval of any of the LGBTQIA patients or people, sorry. And sadly, our own medical system in America at times can be intolerant of our various parts of our patient population. And lastly, our own discomfort at providers in taking a sexual history of our patients or failure in managing our own reactions to some information that might be shared with us may contribute to isolating a patient, putting them outside the reach of human compassion and empathy, and in effect, shunning them, to use a word from Amish culture. Next slide.
Next question, everybody. Please pop in with your answers. The Diagnostic and Statistical Manual, the DSM, which is the book of psychiatry diagnoses, referenced homosexuality as a disease until which year? 1948, 1959, 1973, or 2019? You guys are amazing.
Yep.
Very good. Correct. 1973. Next slide, please.
Next question for everybody. Which of the following illnesses are primarily caused by actions or of the patients themselves? Obesity, substance use, or sexually transmitted infections? People struggling a little bit with that one because that was my attempt at a false dilemma. So kind of putting again the idea of how medical culture can largely be intolerant sometimes of behaviors of people without good understanding of why, just in the framing of the question. So that will move us on to the next slide. What we really wanted to get at is judgment and shame in medicine. Dr. Goodman and I were part of a primary care management council where we were discussing universal screening for hepatitis C. This was immediately around the time when appropriate treatment and cure for hepatitis C had come out. And so we were wanting to ramp up our screening to find the hitherto unknown patients and be able to treat them and move on from there. While we were in the council meeting and discussing our EMR having a universal screening pop-up for providers, there was actually another primary care physician who had gotten upset and actually left the conversation, literally walked out and left. And the concern was that this provider did not want those people in his waiting room. So kind of this assumption of who might be having hepatitis C and what that meant about them. And what that really kind of brought home to me was that as providers, what are we doing? Well, we're called on to provide our knowledge and expertise through a healing relationship with our patients. But some people have a response of intolerance, but really what I'm meaning is judgment, and the corollary to judgment is shame. Well, those are really responses that humans have when someone has morally violated some precept. So something about what they've done is right or wrong. And English language brings this out with the language being I feel ashamed of what I've done, but it's also a verb. You can shame me. So it's both a state and a verb, and that's pretty telling in the English language. But as a doctor or a provider, my job is to provide information and guidance, not judgment and morality, because I'm not there to decide the moral worth of the actions of a person. I'm there to give them recommendations about how those actions may either contribute to or hinder them from their personal goals. And that's very different than right or wrong or morality language. But throughout lots of different examples, and specifically, I would like, as we've been discussing, obesity, body mass index, substance use, sexually transmitted infections, and the entire population in North America of the LGBTQIA patient population. A lot of our language as providers is language of judgment and shame and not knowledge and expertise. So just bringing that out to everybody's awareness. Next slide.
Many LGBT folks experience discrimination in healthcare settings or know someone who has. And so many times people in this community approach healthcare with the expectation of a negative encounter, and they may avoid accessing healthcare altogether. Providers often report discomfort in sexual history taking, and the training is often deficient in LGBTQ unique healthcare needs. Our local example is around rectal PAPs. You know, the first time I was doing rectal PAP, our lab called me and said, "What in the heck are you up to? What is this? Surely you mislabeled something." And, you know, they wanted to throw out the test request. And word has gotten out that this can be a tool that's definitely beneficial and is really easy to do. Our lab is now completely on board. And we have the opportunity to work with our infectious disease folks and other providers and getting this done for people. Next slide, please. We're going to talk about how we can bring hope and healing to this community through our healthcare ministry, and we've outlined 10 steps, and then we have a credit for these 10 steps, by the way, which we've taken from another organization. Next slide, please.
So step one, leadership. The leadership should be actively engaged. Why? Because the leaders set the tone for the whole organization. So that means there should be strategies endorsed by leadership to create buy-in amongst all different staff members about health, hope, and healing, as opposed to judgment and shame. And it needs to be from top down, something that is prioritized from the leadership. Next slide.
Step two, organizational policies protect LGBT folks, protection from employment termination at each level. And even though gender identity and sexuality are not federally recognized categories, having local policies to reflect a protective attitude, anti-discrimination training for all staff, and consider policies, for example, that allow restroom use for all gender identities, such as unlabeled restrooms. I want to reiterate something here. You know, I'm honored to be caregiver for this community of people, but it takes the whole team. The provider herself or himself is not going to get a lot of traction with folks unless the folks answering the phone feel comfortable and get this. The folks at the front desk, your medical assistant or nurse, and all your team members, the folks that cover for you, our NPPA colleagues, everyone sort of has to be on board in order for an office and an organization to be successful here. Next slide, please.
Step three, the physical and virtual environment should be welcoming to the LGBT people. So some examples are welcoming signage, the pink triangle and the rainbow, and marketing could show same-sex gender couples, and it would go far to advertise in LGBT periodicals. I was sharing another story with Mark as well about a particular patient that came to me from a competitor, and they came because their mom was in clinic, and we had some of these signs up in the front, just in the check-in, all are welcome. And this particular patient's adult child identified in the LGBT population and had actually switched providers just because of the basis of a sign, a sense that this is a place where I'll be safe getting my care. So that's a real life example. Next slide.
Step four, the forms reflect options for LGBT people. Correct pronouns and names are available in the electronic medical record. I am not always skilled at this. I don't know anybody who is, but to address people with a sense of what name do you like to be called, and what are your pronouns, can be tremendously bonding to people and give them the sense that, hey, I'm respected and my wishes are honored. Correct gender identification and birth gender available in the EMR, and the appropriate screenings based on the organs present. I want to share a little story. Before the Common Spirit merger, we had the opportunity to revamp our electronic medical record intake forms. We're honored to serve, I don't know now, 340,000 lives, 400,000 lives in eastern Nebraska and western Iowa. And on the very first day that these new EMR changes, which reflected things like, what name do you like to be called? What are your pronouns? Who do you identify as your primary relationship? these changes rolled out in the electronic medical record. And on the very first day, 5,000 patients were reassigned in terms of these criteria, which I thought was just extraordinary. I don't think anybody had any idea of how many people that affected. Individually, as I meet with folks, by the way, they're thrilled. I mean, this matters, and people are so delighted to know that they are included in this sorting that the EMR can do. So hats off to the organization for taking the time and expense to get that done. Next slide, please.
So partnerships with the local LGBTQIA population. As with lots of groups that we serve as providers, having an advisory committee to hear the voice of the patient is a great place to start. Just as a side, as program director for family medicine, one of the requirements is that we have a patient family advisory council that, to kind of paraphrase the guidelines, that accurately reflects the population that is served, and in order to give some feedback back to providers about how things are going and how it feels to be a patient under our care. And we have a number of different patient advisory groups, but one of the things that I would say to be sure is that one of them has at least LGBT thoughts in mind. Another thing that people could do to partner with the local population is consider having a float in the local Pride Parade. The Pride Parade, at least in the local Omaha area, has been growing, I feel like, exponentially the last few years, which is a good thing. So having a particular voice in the community is good, so that people can see, hey, this is a group that cares about our health and well-being. Next slide. That's me too. Sorry, we skipped back and forth a little bit. So step 6, all staff should have training on affirming communications. And what I'm really meaning by this is person first language, which has been moving greater in medicine recently. So teaching the students and residents that I work with, as well as my staff that work with me, as well as myself, to think of Sheila being in room 3, not some slang word or something that I've heard various times in some conversations amongst providers, or just MAs and vice versa, and other people. So staff should have training on LGBT health disparities, problems that are facing this population, and what can the staff do, even up to the front desk staff being trained about preferred use of names and pronouns. And what I'm really talking about here is trauma-informed care through the whole organization, so that everybody has a common understanding of how it is that we talk to each other. Next slide.
Data collection can help too, to monitor for healthcare disparities. What we monitor and report is what we prioritize and protect. Collecting data for this population will reveal healthcare disparities here. Reminder, this is always with consent and participation, again, of the people we're serving. But it's an excellent way to highlight where we can do better in the future. Next slide, please. A reminder that all patients receive routine and inclusive sexual health care histories. I think it's important to practice this, by the way, so that you can take care of people without a lot of drama or anxiety. There's an art here. This is art, being able to use the right balance of sort of street language and clinical language, and to model this with learners. And for all of us, practice makes perfect. I've been at this now for 40 years. and I still stumble sometimes. But there is a sweet spot where you're sort of bonding with people and you're getting the information you need to offer good advice and to take care of people without getting prurient, or also without being overly clinical and using language that people don't understand. I had the opportunity to have a special class one time for the Creighton medical students on body art and body piercings, on tattoos and piercings. And we talked about how important it was at the time to remove piercings for things like MRI scans, and to be aware of why people chose these things and all the reasons, from attractiveness to sexual gratification to all kinds of things. And there were 115 kids in the class, and I got about 111 comments back saying, "This is the coolest class I ever took. This alone was worth all of the tuition at Creighton." But there were 4 or 5 people who said, "Yank his ID badge. He should never be allowed on campus again because this was so raunchy and rotten." And again, gently and respectfully, with that sense of humor and curiosity, to get in there and ask the questions to find out what folks are up to, with the agenda being, hey, how can I take better care of you, and sort of watch for hazards. Thank you. Next slide, please.
Step 9, clinical care services should be able to meet the healthcare needs of the LGBT population. So what does that mean? Be able to provide PrEP, pre-exposure prophylaxis, PEP, HIV health screenings, and it's helpful to have behavioral health tailored to this community. I had been doing some advocacy at the local Nebraska legislature surrounding some concerning transgender laws that were being passed. And one of the things as an outcome from that is some amount of trauma because of some of the legislation. And you guys may have even seen in Nebraska, we made the news because of a couple of local senators advocating for the rights of LGBT people in our community. But the behavioral health to meet with those patients in clinic afterwards with some of the stuff that was going on. So people who are specifically trained or have some interest in understanding in the concerns that they have. And gender affirming care along those lines too. Just as a side note, the monkeypox vaccine, this was a burgeoning public health concern. And there were a lot of places where you couldn't get a monkeypox vaccine, and a lot of places where just discussion about risk factors and who should get it was just not where it should be in the primary care community. We were able to have it at our clinic, largely through Dr. Goodman's efforts, and lots of patients were seen. And that's just an example of clinical care services being able to meet the needs of local patient populations. Next slide.
Step 10, LGBTQ folks or their allies are recruited and retained in the organization. Again, in this very, very odd place here in our community, I being in the community, Mike being an ally, we're doing really, really good work here, and I'll bet you folks are too in your communities. And there are a few things I have done that have been as rewarding as this work, and it's been really, really good for our bottom line. The clinic here also enjoys robust business, and so this is that win-win situation for those who can wrap their head around this and whose heart is supportive of it. Next slide, please. So the references for this are the National LGBTQIA Healthcare Education Center, which is the Fenway Institute, an article titled 10 Things for Creative Inclusive Care Environments for LGBT People, supported by a HRSA grant a couple of years ago. Go ahead, next slide, please.
Quoting Pope Francis, a Jesuit pope and leader that's quoted a lot around here at a Jesuit university too. In July 2013, at the beginning of his tenure as Pope, I remembered this quote. We found it just to make sure that we got it right. If a person is gay and seeks God and has goodwill, who am I to judge? This is exactly kind of the perspective of a religious organization not being judgmental. And last slide.
You've done a great job of staying on time. And there's opportunity to answer some of the questions in the chat and the question and answer place. I'll personally close by saying what an honor it is to be invited to have this discussion. This is obviously less today about the specifics of sexual history taking or pronoun use, and much more about sort of the philosophical bent of the place to be, perhaps to enjoy a successful practice with members of the LGBTQ community. But I'm going to end as I began, with extraordinary thanks, to Brooke, John, Rachel, Dr. Gary, Dr. Sager, Joshua. Josh, I hope to hear from you here too in a moment, because no doubt you have contributions, and don't mean to ever exclude you.
No.
And to our organization, which again, in the world today of some political headwinds about this stuff, we're still going to try really, really hard to be in the right place and do the right thing and take good care of people. So thank you so much.
All right, thank you. That was great. We're going to move to our panel discussion, and we have a couple of questions in the chat. Before we go to the questions, Joshua, you and I have had a couple of conversations separately on, what do we want to talk about, how important this work is, and in your view of the world, how have your teams approached this care? That was one question. And then the other aspect of it is also the fact that our APPs play such a critical role in primary care and comprehensive medical care. So I wanted to ask you to comment on that.
There's an interesting dichotomy with your LGBT care versus care for everybody, but a lot of the principles that apply to care for everybody also apply to LGBT care. So for example, when you write a note about a patient, or when you even talk about a patient, never couch it or phrase it in a way that you would not want the patient to hear. So read your note and then just put yourself in the position of the patient and think, would I want this written about me? And I don't mean like he has diabetes, but I mean like if you're if you're describing somebody as having sex with multiple partners despite conversations with them not to do that, maybe that's not something that is great to put in print. Or another example is I had a patient who had a phalloplasty and he had complications from it, and he went to the emergency room for it. And the patient happened to overhear the conversation between the ED doc and the surgical team, and said, in one of the things they said is maybe OBGYN can bite the bullet and treat him. And we worked with that team on fixing that. But at some level, that's just something you shouldn't say in front of a patient. So you shouldn't say it behind the patient's back, because they may be hearing it. It also frames your attitude towards them. The other thing, I can't underscore that point that was raised earlier about the front desk and everybody else. It's interesting, no matter how good your care is, if the front desk or if the lab staff or if the nursing team are not on board, that almost reflects more on our clinic systems than how the provider treats them. And so when X clinic is awful, it may be just because the front desk was having a bad day or kind of fumbled on things. So that systems perspective is really important. We work hard to train everybody and put them through curriculum modules here at Virginia Mason.
Great, thank you for those comments. Dr. Greensberg, I know that we have two questions. I'm wondering if the first is more of a comment, and I would love to have Dr. Greensberg, your thoughts, Dr. Goodman, Dr. Green, Joshua. It's a comment saying that it is so important regarding sexual history to ask and to not feel discomfort in taking that sexual history and by being overly clinical. So do you guys have tips, one or two tips that you use? Okay, go for it, Dr. Goodman.
My favorite word here is intimacy.
Mm-hmm.
And I teach our students and residents also to use language like this, when you're preparing to enter into this history and you're trying to get information, to say to somebody, hey, we're going to talk about intimacy a little bit. There isn't anything, more important in our humanity than having someone to snuggle with, especially in January in Omaha, by the way. Just going there for a minute. You got to have somebody to snuggle with. And I said, who are you intimate with? Who do you like to be intimate with? Let's talk about that a little bit. And that sort of sets the tone for things. It's I think, an affirming word, and it's not a prurient word, and it's not overly clinical. And I think it's a great place to begin. And then the specifics of, partners and sexual acts and adjuncts and stuff, we can kind of go from there. But that, to me, that feels like a nice, easy place to start. And I think it's a disarming word to choose.
I think that in medicine, we do a lot of things that make us uncomfortable on a daily basis. And, like it's okay to be uncomfortable with things that you're new at and getting used to. And I think we honor that discomfort and then just work on it over time. So if somebody's uncomfortable and willing to learn, that's fine. And I think it's good.
Love it. I love both those points.
I have one other thought, Dr. Sager, if you don't mind. I wouldn't expect anyone to get all of the history and all the right answers the first time out. I see people finally for maybe the 7th visit and additional information is forthcoming. And that reflects, I think, a trust issue. All of us, if we're disclosing, if we're vulnerable with somebody, it isn't going to happen right out of the gate. You're not going to tell all of your stuff at the beginning. And I visit with somebody the 5th time, the 7th time, and we kind of go over this again, and more information is often forthcoming. I don't want to take too much time here, but it's, I think, extremely important too not to have any assumptions about people. We all do sort of semi-second judging. You look at somebody and make a decision. I'm guilty of who they are, where they're from, what their income level might be, what their story is. And oftentimes that's just spectacularly inaccurate. And to sort of suspend all of that instant judging that we do and just let people share their information as they feel safe to do so. The students or residents sometimes go do a history before I do, and they'll come back and relay to me, well, they didn't want to tell me anything, or I don't think I got all this figured out. And it's like, well, you're not a known entity yet. You're not trusted. Watch what happens after you've been caring for somebody for 13 years and you're still getting little golden tidbits of good information that comes. So, don't be afraid to let things sort of happen over time.
I say something to patients really, really often, especially with my new transgender care patients. I say, I just want you to know that you don't have to answer anything that I ask you. If I have a medical reason for wanting to know, I'll tell you, but you still don't have to answer. And that honors that place of distrust in a way that can sort of move towards something that's more open. So I encourage everyone to do that as well.
That's great.
Let's see here. So I'll just comment or two. first, I just want to share something that was, well, actually comment or three. So the first one was, is there an opportunity to, does Common Spirit Health have policy in terms of how gender should be addressed, and how we should kind of organize our clinics? And the answer is yes. And those policies have recently been revised, and we will send out the link to those policies. And we also have some good examples across the country that we can look for to try and have people with personal experience in terms of how that works. But there's been extensive policy that's been developed over the last several years, and I believe the latest revision on Kiddo was just out earlier this year, and I know you commented on it. So that is one thing. The other thing is, I want to just share someone, it was in the questions, but I want to just share this comment, and I think it's a telling comment of where we are at Common Spirit Health. And it says, it's not a question, but a thank you. As a parent of a young adult who has recently come out as trans, I have seen her avoid care and situations to avoid judgment and less than professional treatment. It's so wonderful that we have this type of program. She is also a philosophy major and recognizes that it's a path to understanding, and is so grateful with anyone who takes a step in that path. And so I do think that's a sort of setting comment for us, and who we should try to be at Common Spirit Health in our clinics and our daily life and so forth. There's also a question which I am probably not fully qualified to answer, in terms of the ethical and religious directives and gender affirming care. And so I would just make a couple of general comments. The first one, I admit I had to look up the number of ethical and religious directives we had, but these are the ethical and religious directives for Catholic healthcare. We are a faith-based Catholic system. There are a total of 77, and these 77 ethical and religious directives cover many aspects of care and life. We always think of them in terms of women's reproductive rights, LGBTQT plus, gender affirming care, but they are expansive. And in these directives, I think in addition to very specific directives, there's lots of what I would call clarity about how we should behave. And so just this year, Common Spirit Health sent a letter to the U.S. Conference of Catholic Bishops. It was actually in March of this year. And I pulled out just a little excerpt of that, which I think sort of frames where we are and why we do this work. And it basically, and this is a long letter, which I have pulled out exactly about 6 sentences. And it says, the mission and values of Common Spirit Health call us to recognize the inherent dignity of each person, to create a welcoming environment for all patients, and provide the full range of services available at our hospitals to all without discrimination. We are committed to providing respectful and sensitive care to transgender, non-binary, and gender-expansive patients who have long faced barriers to accessing the care they need. We strive to meet the care needs of all as we accompany them on their healthcare journeys. Our policies prohibit discrimination on the basis of gender identity and expression, and we have a strong commitment to following all applicable federal and state laws. And so I'm not certain how we could make it more clear that that's where we are. And as an editorial comment, I am not certain that that's where all faith-based systems are across the country, but I am quite certain, and I know, Shelley Schlenker, you are on this call, that you in particular have made it clear that this is where we sit in Common Spirit Health. And I think we are all very grateful for your work and to be part of this policy and this approach to care.
Wow, thank you, Gary.
So we're running up against the hour. This has been a great conversation and really terrific. Let's see here. I think we've answered all the questions. I, for one, would like to thank Joshua as a panelist and Mark and Dr. Green. Thank you both. Thank you so much. For us, it's a privilege to get to know people in a different way. And next week at our seminar, I'm going to talk a little bit about my immersion in El Salvador with the Jesuits in 2011. And so I'll talk a little bit about that next week. So it's a great opportunity. So thank you. Ankita, closing words?
I think this has been a wonderful topic, and I think we're just starting to get under the fold of many more topics like this. So thank you to all of you for being on our panel and being our presenters, and of course to the audience members for embracing this topic with us as we continue this journey. So more to come.
Thanks, everybody. I hope everyone on the call has a great end of week, great weekend. Be safe, and more to come soon. Thank you. Bye-bye.
Thank you.
Thank you.